doctors, and nice to see you all in the board as an intern. So my name is Kokila from Quality and Patient Safety Department. Now the department is known as Quality Improvement Department. So the topic for this afternoon, I will talk briefly regarding accreditation process, and we will talk a little more regarding the history of the accreditation in our organization, that is Ministry of National Guard. I'm not so sure how much you are familiar with the accreditation process, but we will just talk a brief. So in general, what is accreditation? It is a formal process by which a recognized body, that is a accrediting body, assess and recognize a healthcare organization meets applicable and predetermined standard. So along this presentation, maybe some terms you all had heard before, or some terms you are not so sure. Don't worry. The moment, this is mainly introduction for all of you. Later on, when you come more exposed to the clinical area, and especially when we're going for the accreditation next year, 21 and 22, you will be more exposed to it. So for this afternoon, just make yourself relax, just a kind of just hearing about it. Don't worry, yeah. And the whole process of the accreditation also, basically the accrediting body will look at the compliance of the organization. So when we talk about organization, basically our organization, and that the organization against the standards. Standards means they already fixed the standard. Later on, you will be exposed to the manual like a book, either Sibahi or JCI. And basically, how they will look at the standards, whether we are complying with that or not, and there will be few activities such as document review. When we say document review, basically they will look at what we have in place, the policy and procedure, and they will interview the staff, and they will do observation. Do observation means they will just observe without asking or anything. So they will look what are we doing. That is the meaning of observation. And also they will do medical record review. So I think medical record review you all very much familiar, because you all may be exposed to how to document in the medical record. And additionally, they will do personal file review. Personal file review means that is our personal file, the individual staff personal file. In that file, basically, they will look at our qualification, our education, our certificate, license, and also our competencies. And the last one also, there's a possible, they will interview patient interview. And usually the accreditation process, it is a voluntary, and the organization must meet the predetermined standard, and the accreditation also goes on based on the cycle of standards development, auditing and improvement, the training education, and all the standards also is evidence-based standard based on the previous incident. That means how the standards comes up based on the globally, the throughout the organization, not only here, global, and anything, the incidents, everything comes up. That's how they create the standards. And it also recognized and endorsed by the WHO, World Bank, and the development banks. And maybe some of you have a query, what is the accreditation and what is the license? Basically, accreditation is voluntary, and when we said about license, it is mandatory. Accreditation basically non-governmental, and in contrast, the license is governmental. Accreditation is optimal requirements, license is a basic, and accreditation is the outcome oriented. License means process, it is more to system and process. Accreditation focus on the improvement. The licensure basically focus on the punishment, and accreditation is public and lessons is confidential. This is no need to worry so much about what I'm going to present. It's just for your information. And the history of accreditation, no need to worry about the year and no need to memorize the year because there's no it is not included in your exam. Don't worry. So basically, it's all started in 1910. The hospital standardization program started in 1918 by the American College of Surgeons, and it goes on 1951 Joint Commission on Accreditation of Hospital. Basically, we are focusing on the Joint Commission. And 58 is the Canadian Council, and 74 is Australian Council. The first accreditation is all started with the American College of Surgeons the American College of Surgeons described the need for standardization of hospitals through accreditation as the need to encourage those which are doing the best work and to stimulate those of inferior standards to do better. That is how the accreditation, the whole process starts with. And with the first accreditation is in 1918. It is the organized medical staff, physician and surgeons are licensed, competent and ethical. They are looking at the first one. But now definitely it is more standards. With the governing body and the medical staff adopts the rules, regulation and the policy governing the organization professional work. It must be accurate, complete and accessible medical records and competently supervised. Diagnostic, therapeutic facilities are available. So now we will talk in brief regarding our history of accreditation in the Ministry of National Guard. This is for the hospital-wide. Initial JCI accreditation in Riyadh, yeah? The first JCI accreditation we achieved in the year of 2006. And after that, we done our mock survey in 2008. Mock survey means it is like more like a consultation. It's like a learning, but it is done by the consultants from the JCI office itself from the US. So they came. We done another mock survey in 2008, and the first JCI re-accreditation. Re-accreditation means after 2006. We did the re-accreditation 2009. So every 3 years we will go through that. So in between mock survey, if you notice, it is not mandatory, but we have done that for 3 years. But the real accreditation must be every 3 years. And then after that, followed by 2011 mock survey. So the second JCI re-accreditation in 2012. So if you see 2006, 2009 and 12 is all 3 years. And the third JCI re-accreditation 2016. And the fourth JCI re-accreditation 2019. If you see in between the third and the fourth, we had initial Sibahi accreditation in 2018. Sibahi accreditation means it is the national accreditation. And apart from the hospital-wide accreditation, we also have departmental specific, which basically mainly is about the laboratory and the oncology services. So maybe this you have heard about the CAP and for the blood bank and also copy certification for the oncology. That one we achieved in 2018. In general, why the organization really wants to go for the accreditation, though sometimes financially it is a bit quite expensive. We have to pay and we have to spend some time for the survey, everything. But what is the need and why we always talk about accreditation? The main reason why all organization wants to go for accreditation because it is enhancing patient safety by effectively managing and mitigating clinical and safety related risk. And it is also ensuring an acceptable level of quality among healthcare providers, stimulating sustainable quality improvement and continuous raising the bar with regards to QI initiatives, and also it enhancing organization understanding of the continuum of care by focusing on performance improvement and outcomes of care. It also promoting capacity building and organizational learning, and it also providing a framework that assist in the creation and implementation of systems and process which improve operational effectiveness and enhance positive health outcome. In general, we need somebody from outside our zone to come and see what are we doing, because if we just doing and continuously doing, after some time you will notice we are not really aware whether we improve something or not. This is in general what is the need for the accreditation. The impact of accreditation on the organization. So once we accredited, so what it gives impacts to the organization. It improves the communication and collaboration in the organization. It strengthens interdisciplinary team effectiveness. It also contributing to better patient outcomes. It demonstrates commitment to quality, accountability, as well as increase credibility of healthcare organization. It also increased the effective risk management and mitigation, including enhanced patient safety. And also this process decreases the variation in practice between healthcare providers. And now, in general, we will talk about what is your role as intern in the accreditation. So, of course, first time in the clinical area, if especially next year, we are our organization going for the hospital Sibahi re-accreditation, either direct or indirect, you will be involved in the accreditation process. So what are your roles? What you must know, what you must have do or anything? We will talk just briefly, yeah. So first of all, you need to be familiarize yourself with the policy and procedure in the hospital based on the scope of your specialty. You need to practice and perform as per hospital's policy and procedure and approved guideline. And the type of care required by all accreditation organization is multidisciplinary care. Therefore, you need to be cooperative and works with other healthcare providers. All the documenting the care provided to the patient in the medical record is one of the favorite things to check by the surveyor. And always remember that if not documented, it's not done. And on top of that also, you need to understand what is your job description. And you need to make sure that you are aware of your responsibility and your chain of command. You need to orientate yourself about the standards related to your work and reflect it into your daily practice. Perform within the privileges granted to you by the hospital and participate in the quality improvement activities and projects and the projects the organization has worked on. This is another important aspect of any accreditation survey visit. So for this year, if you're an intern, so next year you will be the resident. So each time your level change, you need to know your privileges and your job description. And in case you are around during the accreditation week when the outside surveyor comes to your clinical area, so what you have to do during the hospital survey, the do's and the don'ts, we will discuss in general. By any chance, if in case you around during the accreditation, you have to welcome the surveyor to your area. You just allocate appropriate space for the tracer team to do the interview. Basically, this preparation we will emphasize again, just like a few months before the real accreditation. This is just to have some idea at this moment. And if they interview you, just be truthful, describe your regular practice, and just be professional in your attitude and appearance and show respect to the surveyor and reply to the surveyor question directly and very concisely. And if you are unsure of any answer, the surveyor's respond, you just say that you will check the policy or you will check with your immediate senior to you. And keep your answer focused and specific to the question and always answer with the confidence. And if you do not understand any question, just ask the surveyor to clarify or explain to you. And the most important things apart from the do's and what are the important elements that not to do. The most important things, you don't argue with the surveyor or defend your practice. Do not mislead the surveyor with any answers that you give, and do not volunteer unnecessary information, and provide the non-requested document. That means you do not provide any non-requested document. And some phrases like most of the time, we usually, sometimes I do, I think. So this type of phrases give impression to the surveyor. Maybe sometimes we do, maybe sometimes we don't do. And also do not talk about the past survey of the future plan of the department if you are specifically in certain area. And do not give offer any gift because this might be interpreted as bribery. Just give offer water will be sufficient, but this basically will be prepared by the unit managers or somebody like that. And do not prompt the staff during the interview. So in summary, accreditation is the most comprehensive and powerful tool for quality improvement, and accreditation has been found to be effective in many cultures and countries with very different systems. Each staff in the organization has a great role in the accreditation decision, and evidence of the teamwork between all the staff in delivering the care to the patient is the key of success in the accreditation. So basically that's all my presentation, and thank you so much for your time, and we will wish you all good luck for your future. Thank you.
Thank you, Kokila.
Thank you, Ms. Kukila.
Thank you. Thank you. Okay, I'm done, yeah?
Yes.
Okay, thank you, dear.
Miss
I will
Hadil?
stop sharing.
Yeah, thank
Yes,
you,
is Miss
Kokila.
Hadil around?
Yeah, I
Yes,
think Hadil is on the other line.
yes. Yeah, I'm
Okay.
on. I'll start to share my presentation.
Yes, please.
واضحة على الشاشة ولا still؟
بس تقدرين تحركين لنا سلايدز عشان نتأكد إنها
ثواني، هي ما طلعت عندي. كيف أخليها appear؟ أنت قلت
الآيكون اللي بجنب السكيلر تحت على اليمين، الأورنج بار جنبه آيكون تبع السكيلر، بس تضغطين عليه
بس ثواني. واضحة السلايدز؟
واضح.
Okay, fine. Thank you so much. صوتي واضح؟
واضح.
Okay, so I'll start now. Good afternoon, everyone. My name is Hadil Drahim, and I'm the Performance Improvement Manager in the Quality Improvement Department. And I would like to welcome you all into the medical orientation session. Our aim for this half an hour session is to have a quick overview on the performance improvement scope, as well as the functions and the improvement stories. So if you have any question, just you can share it in the chat box. Or if you have any concern as well, I can read your comments.
بس هذه
معاكي تسمعيني؟
أي تفضلي.
Okay, so we will define quality as Institute of Medicine. This is the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with the current professional knowledge. So we are looking for the how to reduce the harm and increase our outcomes in a matter of there is no medication error, there is no harm happening to patients, and so on. So, did you hear about the 6 domains of quality STEEP? This is one of the most influential framework that put forth by the Institute of Medicine, the IOM, which is including these following 6 aims for the health. Some of these measures some of these domains are most extensively been addressed than the others, but the most vast majority of measures that address, and we usually our projects to error is a human. This is building the safer health system. This is a report being issued in November 1999 by the Institute of Medicine that have been resulted in increased the awareness of the U.S. medical error. So they found out that most, around 44,000 to 98,000 of people die each year due to medical error. So from here they came up with the report of the crossing the quality chasm, whereas they came up with this 6 dimensions. If we define each dimension, if we talk about safe, so that means that to avoid the injuries to patients, avoid the harm, timely reducing the weight, especially when it's come to, for example, ER patients, reduce the boarding time and so on. Effective to provide the level of care on a scientific knowledge, which is evidence-based. Efficient, that means there is no waste. Use the allocated resources in a proper way. When it's come to equitable, it means that to provide the care to the patients equally, and patient centers. طبعا أكيد we are talking about dignity and respect for patients. Our priority in the National Guard, that is we need to work as a multidisciplinary team. so in a proactive, preventative way. So not in reactive. So we have to have ahead plans of care to improve the health and well-being of the patient who need the treatment and the support, as well as to have a sustained care and sorry. So when I'm talking about the structure change management, what do we mean by structure change management? Is to understand the current situation and the sense of urgency. So we have the governing body for the strategic planning, which we need to understand and analyze based on the available data and resources to find out where's the problem, figure out the KPIs and selection of the QI projects. Then we start, and this is here our role when we are starting to running the changes in building the capacity and provide the support with to the frontline staff and co-workers, as well as engaging them, the stakeholders and the team to carry out QI projects by using different training methodology when it's come to IHI, Lean Six Sigma, QI tools, and so on. As well as we have to have a communication channel, open communication channel and reporting system through continuous reviewing of the progress and the milestone of the projects, and as well to also to have the dashboard including the KPI, which will measure our success and track our progress. All our projects should be aligned with the NGHA objectives, and I think most of you, if you open the internet homepage, you will find these objectives posted, which is should align with the competent workforce, with the financial sustainability, patient safety and satisfaction, as well as highest quality care within the resources. We keeping on emphasizing on this slide, and this is Edward Deming. He's one of the improvement guru. And when we talk about improvement, definitely we are talking about a process. So 85% of the reasons for failures to meet customer expectation is related to the deficiency in systems and process rather than the employee. So here where we are promoting the just culture and the role of the management, sure that is not to finger point or badgering individual to do better. No, we have to go back and review our system and the process and how to change it to a way that could impact the patient care. في أي improvement projects we should have measures. Is it important? Yes. And this is one of the most important quotes in business management, said from Lord Kelvin, that if you cannot measure it, you cannot improve it. And when I think about this quote, it should immediately become apparent how true it is. Because if you cannot measure something and know the results, you cannot possibly get better at it. So again and again, we keep on emphasizing on measures. You have to select the appropriate measures that where you can track your success and progress. The set of measures that when we are working على أي quality improvement project, we have three sets of measures. We have structure measures, which is related to physical equipment and facilities. We have a process measure, and when it comes to a process, how the system works. والoutcome measure اللي هي final product. فالprocess هي sets that will lead us to the outcome. والoutcome هو التارجت اللي أنا أبغى أوصل له. We have some things that we call it balancing measures. والbalancing measures usually هي الميجرز اللي هي زي ما تقولون potential side effects. When you are working on a project, there's definitely side effect زي مثلا workload على staff when it's come to a change and so on. So these usually not being measured, but in our QI methodology, we are measuring these to find out the impact على الemployee, على الsystem, and so on. we have to agree all and we have to believe if you want to improve even on a personal level you have to have these three drivers of improvements اللي هي أول حاجة الويل and that's mean if you have the will you can change plus خلاص you have the will and the belief you have to have the ideas of changes the proposed change طب أنت عندك will you have the ideas you should know how to execute it to make it real and these are the three drivers for a improvement project that is being conducted in the fulfill areas. The methodology that being used in National Guard معلش أنا أحس إني one way communication صراحة ف I didn't use صراحة إنه أتكلم لحالي بس it's okay. So quality improvement methodology we have numerous modules and all are means to get the same thing. So no matter if we are using the model for improvement اللي هو IHI school, Six Sigma, Deming اللي هي lean أو Kaizen methodology. طبعا عندنا again أشياء يعني زي PDSA زي lean, CQI continuous quality improvement, total quality management. So في كثير methodologies بس all the methodology are talking on how can we improve the system, reduce medical errors, morbidity, mortality, and so on. في أي projects you should have يعني we should have a methodology, a scientific methodology زي ما ذكرناها lean, IHI and so on. The most commonly used هنا في National Guard is the IHI one. طبعا for each methodology there is a similarity حتى في tools they are using the same tools يعني فالtools is very important because it can assist in highlighting the problems and we can know which that need and require change to improve the patient outcomes. يعني tools is similar to the screwdrivers يعني you cannot do anything without having a tool. طبعا ويهمنا the most important thing is to have a system or process that produce high quality outcomes and should be reliable and consistent. This is how to improve and this is اللي هي IHI and I will talk about it in very brief. إيش IHI? The Institute of Healthcare Improvement. This is the framework that guides improvement work. This being developed by Associate in Process Improvement. It is simple and powerful at the same time because it's looking for accelerating improvement and it's and go through multiple PDSA cycle. This is the model for improvement. The model for improvement has two parts and both of them are يعني two parts of equal importance. So we have the to answer the three fundamental questions. This is very essential for guiding improvement work. اللي هي what we are trying to accomplish. How will we know that a change is an improvement and what change can make that will result in improvement. And here when we talk about aim, we have to have a specific aim. measures, identify appropriate measures وهي اللي تكلمنا عليها اللي هي outcome measures والbalancing measures process measures. Changes, this is the proposed change when we identify key changes that will test it and how we will test it. We'll test it through PDSA cycles, plan, do, study, act, and this cycle test and implement the changes in our actual work setting. This is when it's come to IHI or model for improvement. This is the 5 critical components that need to be applied في model for improvement. لما نحكي على model of improvement, so it's about the aim, what we are aiming for in this project, and should be smart specific, measurable, relevant, and so on. And it's process focused and outcome focused. Outcome focused here target, will process focused that the steps that will lead to this outcome. The people who will test, and it's very important to select the people who have a will to test and work in the team عشان we keep a team dynamic, as well as إنه assigning responsibilities for each team member, who's the team leader, the task, and so on. So this is very important when it's come in team formation and selection. Usually in each QI project, it depends on the scope of the project. We are not exceeding very focused and small, 3 to 4 if it's multidisciplinary and more broader. So we can have till 7, 8. But for me and from my perspective, I believe that as small as focused team, this will make it more success. Again, a family of measures, and we are keeping on reassure and emphasize on to have a bundle of measures that will impact on على البروسيس, and you can track your success and tackle if there is any deficiency and problem. Intervention to be tested, and هنا when we talk about the proposed change, that should be grounded into a science. Again, you don't need to reinvent the wheel. For example, if you are working on any improvement project, you can simply go and do some research and search, looking for other organizations, how do they implement these improvement or changes, came with the same ideas. You can customize it upon the work setting and so on. The time, a project should not exceed more than 3 months if the scope is very small. If it's more complicated, could be 6 months to 1 year. الميثودولوجي الثانية اللي نحكي فيها it's the Six Sigma methodology, and again Six Sigma is to improve the existing process or product that we use. So exist process that we have to go through these phases to define what is our priority that we need to work on, and to define our clients and customer measures. How is the process performing, analyzing to find out the causes and effects, improve how do we improve it through PDSA cycles. Control as well, and how can we make the improvement sustain and maintain. These are the 5 steps. Again, لما نحكي على define, as we said, we define our priorities. The problem that we need to solve should be clear. And here where we create a tool اللي هي improvement charter. A measure, I need to understand where's the problem, and here where we use the flow chart. Analyzing, there's a different tools that is apply in analyze phase, such as the fishbone. And for the physicians, they are engaged more into some root cause analysis, morbidity and mortality cases, which usually they use the fishbone diagram to generate an idea and get to know the causes and the sub-causes that lead to this complication that happened to the patient. For the improve phase, here where we use the PDSA, came up with testing and piloting the solutions. We'll control how we can make it controlled and sustained, and make sure for a improvement project, you need to have a questionnaire or whatever methodology that you use, but you should review and assess the process continuously, update your storyboard, and you have to share your challenges and lessons within the team. Again, this is an integrated approach. Want to use again, it's all the same. Everybody would like to use the Six Sigma, the Lean, or the model for improvement. But usually here in National Guard, we are preferring to use the model of improvement because it's more convenient in the clinical area and easy and visible. طبعا في لها tools يعني I didn't share معاكم tools تبعت project charters, tour of the measures, the templates that we use. في طبعا البلان PDSA as well, it's have its own tool. I'll walk you quickly through one of an improvement project اللي هي reducing related injuries to newborn. And this came from the obstetric and gynecology department. And the main driver for this project, it's one of the priority goal. And there is SRS. I'm not sure if you are familiar with the safety reporting system. This is an electronically system where the healthcare workers report any incident happened to the patient or near miss. So this is one of the it was one of the SRS trending, and as well as the patient experience, we get the feedback from a patient where shows that there was a problem happened. This project impacts safety, and when we talk about safety, that's mean the harm. And the patient centers that it's طبعا أكيد يعني we have to deal with the patient in a respect and dignity. So these are the impact. And impact is related, aligned, with the IOM, اللي هي 6 dimensions. The problem came up that number of birth-related injuries was very high and trending. There, as you know, on a yearly basis, we have more than 8,000 deliveries, and the rate of the injury was 10 times more than the international figures. And when we review the SRS, we found out that there was a problem, and it's shown here in the graph. You can see that there is a number of birth trauma is 26 highest than the international benchmarking, which is 2.1. So we came up with an aim, which is a smart aim, to achieve a zero birth-related injuries by the end of January 2017. Zero birth-related is not realistic, but as we said, we would like to achieve an ultimate goal where we يعني ما يكون في أي injury, any harm happen to the patient. We try to push for that as much as we can. But is it realistic? No, it's not realistic. لما نحكي على الميجرز طبعا again outcome measures اللي هو related to our aim is the birth related injuries to be 0 per 1000 birth. البروسيس ميجرز هي الستبس اللي بتساعدني اني اوصل للاوتكم ميجر, وهي it's about compliance with protocols and algorithm and protocols. There is a protocols as well as انه it's been reviewed, as well as we are looking for educations and workshops, drills, competency assessment, which should be done يعني دائما. البالانسينج ميجرز اللي هي حكينا عنها السايد potential side effects. لما أنا أجي أضيف أي بروتوكول جديد أو أي process جديدة, I have to figure out that there is a workload on the staff. So staff satisfaction is very important. في resistant أكيد في resistant to adhere to protocols, something new أكيد حيكون في resistant. To follow competency assessment, أكيد there is a resistance and fear as well. As you know, people usually have a fear of change. Again, إنه واحدة من الأشياء إنه we have to figure out if there is any increase في rate of C-section على أساس إنه يعني some of the physicians They don't want to be considered that they have the high harm, so a high number of harm patients. So let's shift it from normal delivery to C-section. So these are a balancing measures. في أي project we have to have a multidisciplinary team, and the multidisciplinary team should يعني طبعا you have to select اللي هم most appropriate team اللي هي we need a consultant as a team leader, we need a resident, neonatologist, quality improvement specialist who's doing the improvement coach, nurses as well. كمان أحيانا we need more members, but it's not as a permanent member. لا, we can invite them as needed. زي ال ISD مثلا اللي هم أو اللي هو medical informatics and so on. Especially when there is a changes في best care system and so on. طبعا after we start, you know, as we said, we are targeting a zero harm. We keep on tracking. Our outcome measure is the rate of birth trauma per 1,000 delivery, and you can see إنه numbers started to go down, but still we didn't achieve to the zero. But inshallah, and still the project is ongoing. These are basically about the quality or performance improvement unit. Just I want to share معاكم يعني it's initiatives you know how you know we try to help as much as we can, but sometimes we cannot cover everything. So we design a new building learning system capacity that based on a one-to-one coaching. This initiatives started on April 2017 to support clinical and non-clinical staff into يعني improving quality and patient safety. And all the initiatives should align with the IOM 6 dimension here: safety, effectiveness, efficiency, and so on. These project drivers support our organization goal, accreditation, KPI, safety reporting system, and so on. And these sessions or initiatives designed as a weekly clinic to coach whoever need a help and whoever from the healthcare professionals, workers engaged in any improvement project. We design a form for application as application form, and we found out the most يعني who visited us in the improvement clinic came from nurses, others which is including pharmacy, respiratory therapist, rehab, and so on. And the lowest number, as usual, is the physician. طبعا we aiming and we are believing in quality improvement clinic is to we came up with this theme: better me, better service with the better care. And we are trying to support as much as we can and help with our existing resource, the frontline staff, to be engaged more and more in quality improvement initiatives. Thank you. I'm done for the performance improvement. I don't know if you have any question.
Thank you, Ms. Hadid.
If you have any question, you can just tab in the meeting chat. So
There is a 10 seconds delay. Just give them a minute.
oh, okay, sure. So I can leave now. There is no question.
Thank you, Ms. Hadid.
Okay, thank you so much and have a good day. Thank you.
Mr. Romel,
Yes, Miss Noof. Good afternoon.
good afternoon. You can start.
Okay, this is a presentation appear in the screen.
Yes.
Okay, thank you. Good afternoon, everybody. This is Romel Casilla, a quality specialist, and I will talk about the JCI and the CIBACI essentials or international patient safety goals. Okay, as a while ago, while Miss Kukila, the first presenter, saying that regarding the accreditations. Okay, so in here in Ministry of National Guard, especially in our institutions, all of the facilities in each region already accredited by Joint Commission International and SIBAHI. Okay, SIBAHI is the national or the Saudi Arabian accreditation body, while the JCI or the Joint Commission International is an international body. Okay, so the IPSG or the International Patient Safety Goal, I will present this first. Okay, these are the problematic area internationally in healthcare as described, evidence and expert-based consensus solution to be in the problems. Okay, that's why we have 6 of them. Okay, the objective is to, at the end of the sessions, residents or the medical interns will be able to acquire knowledge on the International Patient Safety Goals or the IPSG of the JCI, and the same time with the ESR or the Essential Safety Requirements for the SIBACI or the Saudi Central Board for Accreditation. Okay, this is the Saudi National Accreditation Body. And to understand the importance of the IPSG and the ESR in the organization. Okay, the IPSG and the ESR are the acronyms of these two. Okay, the International Patient Safety Goals or the IPSG are the important guidelines at the international level to promote a specific improvement in the process of providing safe and high quality patient care and promotes a specific improvement in patient care and highlights problematic area in healthcare, describe evidence and expert-based consensus solution to problem related to patient safety, and focuses on the system-wide solution. As you can see, the important one of this IPSG, okay? I know medical interns during your rotations inside the hospital, be in mind that this IPSG are all implemented, okay, in all clinical area and non-clinical areas, okay? And if one of you during your rotations in the clinical area, anybody healthcare workers reminded you to follow these 6 international patient safety goals or IPSG, just make it remind yourself, okay? Because it's already implemented effectively in the clinical areas. Okay, we have the goal 1. This is to identify the patient correctly. Okay, as you can see in the picture, that the hospital develops and implement a process to improve accuracy of the patient identification. In the organization that we have a patient's identifiers, 2 unique identifiers. They are the MRN or the medical record number and the full 4 names of the patients. Okay, so this is what it goes. Okay, the reliability identify the patients as the person for whom the service or treatment is intended to match the service or treatment to the patient. And the process I told you that we need at least 2 identifiers. patient's name, identification number or the medical record number, the birth name, or barcoded wristband. Okay, as you can see the picture, the barcoded wristband. And the identifiers required before providing treatments. Okay, that's why during your rotations in the clinical area, most of the time nurses or other healthcare providers, they are checking the ID bands, okay, before giving or providing treatments, especially giving administration of medication, administration of blood products, services restricted diets, okay, those who are restricted diets for patients, providing radiation therapy, okay. Other one is before performing procedures like insertion of intravenous lines or hemodialysis, okay, and before also diagnostic procedures. Those diagnostic procedures are performed like the cardiac catheterization, diagnostic radiology procedures, okay, taking blood samples or specimens, and correct identification of patient in special circumstances. You know those special circumstances, those as comatose patients, newborn, and not yet immediately named, okay? That's why they are putting in a newborn with a unique identifiers based on the mother and to the patient itself. Okay, comatose patients, you can see now those are cannot be expressed or cannot be asked or cannot be talked. That's why they are in special circumstances to need to be identified immediately. Okay, we have the goal number 2, improve effective communication. The IPSG number 2 is hospital needs to develop and implement a process to improve effectiveness of verbal and or telephone communication among caregivers. Okay, this is problematic also internationally because as you can see the safe practice that we have a policy and procedure in the organization that we need to write down or entering into to the computer a complete order, okay, either verbal or a telephone or a test results by the receiver, and the receiver is reading back the order or test results. So this is a two-way process. For example, a doctor and a nurse, or the doctor is giving a communication and order telephonically or verbally. Verbally means to say face to face, okay? And telephone, as you can see now, telephone or my mobile phone, so they can read, the doctor read or verbalize what he ordered, and the receiver or is reading back what is written or giving or verbalized by the doctor, okay? And also the sender or the doctor will confirm what has been written down by the and read back is accurate by the reading back or the nurses. Okay, that is the process. That's why you must familiarize the policy and procedure of the organization. Okay. And we have also the improvement effective communications. This is the IPSG 2.1. And the hospital needs to develop and implement a process for reporting critical results of diagnostic tests. Okay. For example, a patient have a test for his blood sugar is high, okay, critically high. That's why we need to report to the doctor or the MRP or the responsible physician, and the process the same as it goes in this safe practice that we have. Okay, this is now other way around. The nurses will report to the doctor, and the doctor now will read back and confirm by the nurses or the laboratory technicians or the radiological technicians. Okay, so whoever where the test results happen. Okay, as you can see, the practice, the critical tests and critical values should be identified and defined by the organization. So we have a policy regarding this one, and to whom and by whom these results are reported. Information to be documented in the medical record must be identified, and the compliance should be monitored. Okay, we have a nice and brief policy and procedure regarding this one, either laboratory and radiology test results. Okay, and IPSG 2.2. Okay, the hospital develops and implements a process for handover communication. Okay, this is gonna be a critical for communication process. This is what they are calling endorsement. Okay, because sometimes during endorsement, especially here in our organization, that we have lots of accents, we have different cultures, we have different nationalities. That's why we have different type what we pronounce a word, a letter, a number. That's why we need to be improved to be effective communication during endorsement. Okay, so the same practice, we need to standardize critical content in communicated between healthcare practitioners and a standardized method, form, or tools to facilitate consistent and complete handovers. So we have a policy and procedure also regarding this one. I know all of you during your rotation as internship in the organization or in the hospital, you need to know what are those policies and procedure of this IPSG. Okay, in handover or patient care, okay, this is, for example, between healthcare practitioners, okay, to physician, nurses to nurses, or nurses to physician. Okay, this is the endorsement process. Or between different levels of care in the same hospital. Okay, this is now the transfer, okay, of services, okay, of the patient. Maybe the patient is from general ward to ICU. Okay, so you need to communicate or endorse the patient to another unit. This is now unit to unit or department by department. Okay, inpatient units to this diagnostic other treatment department. So as I said to you now, this is now for transferred or any procedure like going to radiology or rehabilitation services. You need to communicate again to the receiving healthcare worker there. Don't just push the patient and leave. Okay, you need to be endorse again what is the specific data needed by the patients to the receiving department. Okay, the last one is between staff and patient and family during discharge. Okay, we need, if during discharge now, we need to educate now the sitter or the patient by itself or the caregiver of that patient. Okay, either one of his family or one of his paid sitter, whoever, we need to educate, we need to communicate safely so that the continuation of care to the patient during discharge or during discharge home will be practiced. Okay, so that's why communication is the best way. Not only just only discharge the patient, kalas. Okay. Okay, we move now to goal number 3. Okay, this is now regarding the safety of high alert medications. We are talking now in this goal number 3 is more on medications. Okay, IPSG number 3 is the hospital develops and implements a process to improve the safety of high alert medications. Okay, as you can see the picture here that some of medications here in the organization that they have been labeled high alert medications. There are some colored coded, okay, to be standardized what are those high alert medications. And high alert medications are those medications involved in the percentage of errors are on sentinel events. Okay, sentinel events later on for the next speaker, they will talk about sentinel events and errors. Okay, so you can understand what are those sentinel events. Those are, if I'm not mistaken, those are getting harm okay? Patient's harm based by the given medication because it's high alert, okay? These are the medications that carry higher risk for the abuse or other adverse outcomes. For example, investigational medications, controlled medications, chemotherapy, anticoagulants, psychotherapeutic medications, and look-alike, sounds-alike, or the LASA medications. Okay, we will discuss it in the next slides, all those medications that are high alert. Okay, the high alerts and look-alike medications should be readily available for the staff, and there should be a process for prescribing, preparation, administration, monitoring, storage, and labeling. Okay, as you can see in the pictures here, there's a 2 vials and 2 ampoules. Okay, as you can see, they are look-alike, and then the ampoules are look-alikes, but they are different medications. The other one is atropine, and the other one is adrenaline. Okay, so if maybe the doctor ordered atropine and you mistakenly pick it up the adrenaline, okay, so you give it already a medication error to the patients. Okay, so if that medication error is already administered to the patient, maybe something wrong, okay, make the patient harm, so it lead to be sentinel event. As you can see also in the other one, the vials, this is now one of the sample of sounds alike. When you read vicoronium versus vancomycin, see, they are started with letter V. Vicoronium, vancomycin, so they are sounds alike. So maybe, as I said, if vicoronium is the ordered one, but you pick it up or write it up the vancomycin as you sounds alike, so that's gonna be the problematic of this goal. Okay, improvement safety of high alert medications, IPSC 3.1. Okay, again, the hospital developed and implement a process to manage the safe use of concentrated electrolytes. Okay, the concentrated electrolytes are the like potassium chloride, okay, calcium chloride, like that. But as you can see, there's still a look alike and sounds alike of these two patients, but they still classified as high alert medication. But in this next slide, we are talking about the concentrated electrolytes, okay? The area are clearly identified where concentrated electrolytes is clinically necessary, okay? And the process for labeling, storing in the patient's care units is restricts access and promote safe use, okay? Because these concentrated electrolytes are very dangerous when it's not properly administered to the patient, okay? And we go now to the goal number 4. This is regarding all the surgeries, okay? Ensure safe surgery that we have. That's why we have the IPSG number 4. And the hospital again develops and implements a process for the pre-operative verification and surgical or invasive procedure site markings, okay? As you can see the picture there, you can see the arrow. We can go for that arrow later on, we will discuss. Okay. Preoperative verification process is verifying the correct patient's procedure and the site, and it also ensure the relevant documents, images, and studies are available, properly labeled and displayed, and verifying also the required blood products or special medical equipments or implants are present. Okay, this is now the verification. In the verification process also include the IPSG number 1. Okay, this is the process. You are checking now the ID band if it's a patient having a correct patient. Okay, by looking his medical record number and patient's name. Okay, that's why this is not a pre-operative verification process. Everything you are verifying, okay? The procedure, if it's based on the consent, you can see now verify that this is for that particular procedure, and the same with the consent, okay? In site markings, okay, this is now what you can see in the picture, the arrow that done by the person performing the procedure. And in IPSC 4.1, this is now the hospital develop and implement a process for the timeout that is performed immediately prior to the start of the surgical invasive procedure and the sign out that is conducted after the procedure. Okay, see, you can see the picture that are doing timeout. The sign is timeout. Okay, timeout mean to say is not a timeout that is finished already that procedure, but it's a timeout to begin the procedure. Okay, that's why you can see timeout that is performed immediately prior to start. Okay, okay, this is now the process. Full team actively participated in the process, as you can see in the picture a while ago, that the nurses, the physician, the surgeon, or the anesthesiologist, they are all involved. Okay, must be done immediately before starting the procedure. Okay, must be done in an area which the surgical invasive procedure will be performed. See, as you can see in the picture, this is inside in the theater. Already the patient is in the table, and then they're about to start the incision for the patient. Okay, before they start to cut or to open or to slice the skin of the patient. Okay, because they are already verified. Sign out is done before the patient leave the area with the surgical invasive procedure was performed. Okay, and the component includes name or surgical invasive procedure that was recorded. Okay, if it's the same, count are completed. Count means to say they are counting all the equipment, the materials used during the procedure, labeling with specimen if it's needed. Okay, and equipment problem that is needed to be addressed if during the procedure or during the operation in the table in the OR, that if something wrong with that equipment, they need to be addressed so that the next patients on that table, they will not be used that the same equipment because it's already problematic. Okay, we go to now goal number 5. Reduce the risk of healthcare associated infections. In this goal number 5 is talking about infection control. Okay, how we deal with infections. Excuse me. The hospital adopt and implement evidence-based hand hygiene guidelines to reduce the risk of healthcare associated infections. As you can see the picture, and you can see this picture all around the clinical area. Okay, because all the healthcare worker must be follow and adopt this procedure. Okay, as you can see, there are 5. These are the 5 moments, okay, of hand hygiene as they are called. Okay, before, first one is before touching the patient. Second is before a procedure. 3, after procedure or body fluids exposure risk. Okay, and the fourth one after touching the patient. And then the 5th one is after touching a patient's surroundings or anything that you touch during your rounds or your rotations in the clinical area, you need to do hand hygiene. Okay, hand hygiene means to say if you use the alcohol base or used by soap and water. Okay, just only the 2 hand hygiene that we have in the organization, alcohol base and soap and water. Okay, wash your hands. Okay, IPG. We move now to IPSG number 6. This is now talking about a patient's harm resulting from falls. Okay, and the hospital needs to develop and implement a process to reduce the risk of patients' harm resulting from falls for the inpatients. Okay, 6 for the inpatients and 6.1 is for the outpatients. Okay, because some vulnerable patients, not only in the inpatients or in the ward, but also happen in the outpatients or in the clinics. Okay, that's why we need to look at it, what to be to prevent the patients from fall. Okay, those are the 6 international patient safety goals from the JCI, and the 6 international patient safety goals have all policies and procedure you must need to read before you go to your rotation or your internship in the clinical area, so that you know what's happening, because this is a fully implemented in the organization in the clinical area. That's why sometimes the nurses may try to remind you, okay, to implement, to do this from IPSG number 1 to IPSG number 6. Okay, so we move now to essential safety requirement, or the ESR, for the SIBAHI, or the Saudi Central Board for Accreditation of Healthcare Institution. Okay, as you can see, this is the logo. This is the Saudi National Accreditation Body. Okay, as okay, we have 24, but some of these 24 ESR are the same with the 6 JCI IPSG. Okay, at the same as the requirements. Okay, these essential structures and practices that hospital undergoing SIBAHI accreditation must have in place and be in full compliance with, to minimize the risk of serious harm and death for patients or the staff member. Okay, these 20 ESR are problematic areas, okay, or problematic practices done in the organization or in hospital. That's why SIBAHI or the JCI also look at this to prevent, okay, that will not be happen. Okay, a partial compliance will not be accepted for any SR during the accreditation. If we need to be fully met the 20 SR and the 6 JCI IPSG. Okay, the same concept during accreditation. Okay, the ESR requirements selected based on their level of risk on the patients, like proximity of risk, probability of harm, severity of harm, and number of patients at risk. This is the criteria for the SIBAHI, why they are looking at the 20 ESR. Okay, we start now. We have the ESR, the Human Resources, or HR.5. This is now talking about for the process for proper credentialing with staff members licensed to provide patients care. Okay, so as you can see in the picture, this is the credentialing or the requirements or certifications or credentials that you are qualified to do so. Okay, that's why all the staff in the organizations, even though as of now, as medical interns, residents, and staff nurses or staff physician, they are looking now all the requirements. Okay, that's why during the last previous accreditation, medical intern files are also already included as reviewed by the surveyors. Okay, medical staff, or the MS.7. This is a medical staff members have current delineated clinical privileges. Okay, this is talking about not our physicians, our doctors. Okay, they must be current their clinical privileges, what they're doing to practice what they privileged to do. Okay, maybe just like you and as medical intern, you are not privileged to do such procedure. Okay, you're just only privileged based on your knowledge. Okay, what level that you are right now. Okay, don't do and jump any privileges or any procedure without supervision of your supervisor or whoever is with you during your rotations or internship in the organization. Okay, you can do as long as permitted and you have a supervisions. Okay, provisions of care, or the PC.25. Okay, this is now regarding the blood products. Okay, how to handle, use, administration blood products. Okay, we have a policy regarding this. All the IPSGs and the ESR, we have policies regarding this one to follow. Okay, that's why, as you can see in the IPSG, that the hospital develops a process and implements. So those are talking about a process or a policy to be followed. Okay, okay, this is now another provision of care point 26. regarding the development of venous thromboembolism identified and managed. So we have now a process how we can manage the venous thromboembolism. Okay, how we take care, how we care, how we manage to care this kind of disease. Okay, quality management or patient safety or QM.17. This is a hospital or process to ensure correct identification. Or see, as you can see, this is now the IPSG number 1. Okay, internationally and locally, the same as problematic. Okay, and QM18. As you can see the picture again, this is a process to prevent wrong patient, wrong site, and wrong surgery procedure. This is the IPSG number 4. Okay, it's talk about surgery. Okay, talk about the process how to the patients in doing the surgery procedures. Okay, you can see there are the patients. Okay, the sites. Anesthesia care or AN.2. Anesthesia staff members have the appropriate qualification. As I said before, that all the staff of the organizations, they need to have qualified. Okay, they need to be certified. They need to be have a degree. Not only go in the organization, jump up in there and do it as an anesthesiologist or registered nurse or as a physician. Okay, you need to be a qualified or any degree that you have. Okay, in anesthesia, AN.15. Okay, a qualified staff perform moderate sedation and deep sedation analysis. So, okay, so that's why we have a training regarding BLS or basic life support, pediatric, any of this ACLS or training of this certification, we need to be qualified to do so. Okay. Infection prevention control, IPC.4. Okay, this is now a designated multidisciplinary committee that provide oversight of the infection and prevention program. Okay, this is all about the infection control management. Okay, this is now a multidisciplinary, not only a one person or one department. That's why it's all the department of the organization have a representative or designated as part of the committee to prevent the infections. Okay, infection IPC.15. Okay, facility design and available supply support isolation practices. Okay, as you can see in the picture that we have the full gear to prevent the infections, especially in isolation processes. As you can see now, we have suffering the pandemic of the COVID-19. So we need to prevent as a gear, okay, for the isolation processes. Okay, medication management of the M.5. This is IPSG number 3. Okay, hospital system for the safety of high alert medications. Okay, talking all about the medications regarding high alert medication, the look alike, the sounds alike, and see the same as MM.6. This is now the LASA, look alike, sounds alike medications. And this is now also MM.41, how controlling and reporting significant medication errors. Okay, that's why SIBAHI or the Saudi Commission that we need to be familiar or vigilant and reporting the significant medication errors happening. Okay, that's why we need to report, and we have a reporting system in the organization. Later on, the next presenter will talk about how we deal, how we report. Okay, we have a very nice system because in reporting of such medication error, it will guide us, okay, as a lesson learned that it will not be happening again to the next patient or happening to you, happening to another staff. Okay, that's why we need to be improved. That's why, if you remember with Miss Hadil, that presenter a while ago, that we need to improve everything. That's why we need to measure. That's why we need to report any medication error. Okay, even though near miss. Okay, even though near miss, we need to report to improve. okay, our system. Laboratory, or the LB.51, is all about blood products. Okay, so this is gonna be the how blood product transmitted infections. Okay, facility management, or the FMS.9. Okay, it's all about, this is now all about occupation and safe from radiation hazards. Okay, that's why if you can see this safety sign, that this is a radiation area, radiated area. Okay, FMS.21 regarding now effective fire alarm system. Okay, so we need all, I know when you have your rotations internship in the organization, I know you are provided to go in our fire department for a training, a certifications for the participations, how we deal with fires. Okay, see, and FMS.22 regarding again fire safety, how we deal with to suppress, how we deal to handle, how to use especially the fire extinguisher. Okay, this is a fire alarm, this is a fire hose, and this is a smoke detector. Okay, that's why I know you are having a schedule for your fire and safety certification in our one of our fire department. FMS.23. Okay, this is talk about fire exits. Okay, and properly located in the hospital. That's why observe everything that we in our environment, especially fire exits. Okay, as you can see in the pictures. Okay, the stairwells, the bar of the fire exit door, fire extinguisher. Okay, those area must not be blocked. Okay, that's why be vigilant that if something observe that there's block in this area, maybe you need to help the environment to remove those block on those areas. Okay, FMS.24. This is now talking about own occupants are safe from fire and smokes. Okay, that's why we need to rearrange. Okay, we need to have a safe area. That's why we need to have to do the signage, observe the signage. Okay, familiar with the area, so that we need to be safe. Okay, during fire and smoke, we need where to find a way to exit. Okay, FMS.32. I know, I guess this is the last slide. As you can see, this is a proper maintenance of the medical gas system. Okay, this is not a medical gas bulbs. Okay, when you have your internship or rotations in the hospital, especially in the clinical area, you can see these bulbs that's for oxygen, for nitrogen, or whatever medical gases in there. But most of the time in the ward are oxygens. Okay, so those are the oxygens we need to be observed. Okay, and thank you. Any questions? You can type your questions in the chat box.
Thank you. We have
Okay,
Rasha now. Miss Rasha.
Yes, hi, good afternoon.
You can start.
Can you hear me?
Yes, dear.
I'm gonna share my slide and please let me know if it's shared already. Can you see the slides?
Yes, dear.
yes, Rasha, we can see. Make it full, Rasha. Okay, I'll out now.
Can you see now?
تقدري تخلينها بس full screen.
Just a minute. Is it obvious?
Yes.
We can
Okay.
see. Okay.
All right. Thank you. Good afternoon, everyone. I'm Rasha Al-Ahmari. I'm a quality improvement specialist working under the unit of patient safety, and I would like to have a chance to talk to you about a very important aspect of our work as a quality, and you're gonna be hearing this a lot during your practice. I'm going to talk about the safety reporting system, the SRS. Our content will go through some definitions about that are mostly used in the patient safety, and then we're going to see the safety reporting system overview, and then we will go through what should we report and the 24 mandatory reporting incidents. Then we will move to the safety report submission process and why we should report and how to report an incident, and then we'll end up with good catches. So basically, I would like to define the safety report as the mean of reporting any undesired incidents that might have affected the patient, employee, or family member, visitor, or facility, or even an equipment. This incident should not be consistent with the standard of operation or care. So basically, it's the incidents that happened which is opposite to that standard of our operation of care. So these incidents might have caused an actual injury or a damage, or it is possible to cause a potential injury or a loss of function or death. Then I'm gonna define the near miss, which is an event or situation or an error that took place but was captured before reaching the patient, staff, visitors, or a facility. So basically, safety reporting system is a web-based incident reporting and management system. It is easy to submit, refine, analyze, and communicate incidents information. Any healthcare provider can use it to report. It focuses on identifying and preventing the process and system failures, as we can say that like 85% of the incidents that happens is actually a system failures, and only 15% of the incidents that are reported are human errors. So basically, we are identifying the system failures. Quality and Patient Safety Department encourages and appreciates the reporting. Also, you should know that reporting is very confidential. I'm gonna take you through a scenario. So this scenario happened actually before. Mr. A was admitted as a case of acute basal ganglia stroke. He developed MRSA pneumonia requiring an ICU stay treated with antibiotics. After the ICU stay, he was shifted to Ward X, Room 10A. He was cohorted with a patient who had a staph capitis bacteremia seen on blood culture on the 12th of February. On the 18th of February, while Mr. A was recovering from his MRSA pneumonia, he developed fever and leukocytis. The resident on duty was informed that Mr. A's blood culture came out positive for staph capitis bacteremia, exactly like the patient he was cohorted with, Mr. B, in the room 10B. So actually, this is a question I was planning to say it in front of you and have your feedback, but I'm going to answer myself. If you are the resident in this scenario, would you report this SRS or this incident? Actually, yes. This incident was reported, and it was reported by a resident R1 as a risk of infection cross-transmission. So, what to report? What incidents should we report? So basically, we can report any incident that is inconsistent with our standard of operation or care, whether it causes a potential harm or it caused an actual harm. These are a 24 mandatory reporting events. So basically, if any event from these 24 incidents we have that happened, it's a mandatory to report. Let's go through them. For example, the blood transfusion reactions, electric shock to a patient, serious medication errors, infusion of contaminated blood, misplacement of the tube IV line, for example, nasogastric or catheters or drains, in hospital stroke, and any incidents involving a restraints, any abduction of a patient of any age, any patient fall, any hospital acquired pressure ulcer, adverse adverse drug reaction, and irretrievable loss of a biochemical sample, patient suicide attempt or suicide or any self-harm, presence of a metallic object, for example, like a pacemaker or while doing an MRI test, burning of a patient visitor, staff rape or assault or homicide, surgery or invasive procedure to a wrong body part or a wrong patient, death during or immediately after surgery or invasive procedure, death or injury of any neonate fetus, including intrauterine fetus, and any labor death, also retention of a foreign body in a patient after a surgery or invasive procedure, failure to follow up or communicate critical lab results, radiology tests, wrong medical gas delivered to a patient, or the last one is wrong surgery, invasive procedure to a patient. So basically, these 24 incidents, it's a mandatory to report, and it will be questionable if something like this happened and wasn't reported. I'm gonna take you through some examples of our reportable incidents. We'll start with no consent or incorrect consent or procedure, and the consent differs from the OR list. Wrong patient identification, correct surgical site not marked, also unplanned return to OR within 30 days related to initial surgery procedure performed, unplanned admission to ICU, intraoperative mortality, unplanned blood transfusions, unplanned removal or repair of organs, and any changes in or of procedures. So there is a process for submitting a report. Actually, it's a more complicated than this, but I think this is the most appropriate for you to know. So an incident occurred or it was discovered. What to do next? Report the incidents in the SRS within 24 hours. Then this report that you've issued, the incident will be reviewed, and risk assessment and management by key stakeholders. For example, our department, the Quality and Patient Safety Department, MRP, and department liaisons. All of those will be reviewing the incident that you've reported. Then after that, a feedback provided to reporter two in the SRS safety report is closed. So you can always check when you report, you have the file number, and then you can log in again and see our resolutions notes. So we'll come to the topic why we should report. There is a lot of benefits of reporting an incident in the system. First of all, it helps us identify hazardous and risks behavior. It helps us also prioritize where to focus our resources. It enables us to use the data to develop interventions to mitigate these hazards and prevent recurrence. If you remember, my colleague Ms. Hadil were talking earlier about the project of reducing neonatal harm. Actually, that project was triggered by our data from the SRS. So we've basically received a lot of incidents, and then it triggers us that there is a problem with the neonatal harm. Then from there, it was the starting point of our improvement project. It also helps us, enables us to evaluate whether the intervention we've made reduce the harm or not. Also, we can use it as a measure of a progress towards achieving a safety culture. So basically, now my friend and my colleague Rayan will be continuing with you on the process of how actually to report. And Rayan.
مرحبا هلا.
I will
share my slide, yes, please.
Okay. Thank you.
السلام عليكم، مسيكم بالخير جميعا. معكم ريان الدويرج, quality specialist. Before we starting to demonstrate how report an incident, let us know how it's work, why it's important to report. Safety reporting systems are used to manage the data surrounding an incidents and injury in the workplace among healthcare worker, patient, visitor, and etc. So each reporting system is customized to fit industry and the organization. Common elements reports in the safe reporting system related to event, including data, time, nature of the event, causes of the event, injury, name of injury parties, description of the event, location, where was it happen, if it's witness or not, requiring medical care or not, mitigation. So if we have these data, we can work to improve the patient experience as well as health workers. So while you're having an incident and you want to report it, you have to go to National Guard portal page, which is this page. So you will select the e-services. Another page it will open to you. Okay, in the e-services. So down here with the circle, you can see from here you can enter the SRS system. You will log in with your username and password of your email. Then you will select in which city you are, like Riyadh, Medina, Hassa, Dammam, anywhere. Then this page, after you log in this page, it will open to you. We have almost 18 categories, which starting from like surgery procedure, drug, airway, and etc. So are you having an incident but you don't know which is the right category? Like take an example, needle stick. What you have to do, it's you writing here in the find like a keyword of the incident, so it will eliminate the other category for you. Then you can choose the right one, like say needle stick. So it will eliminate the other. It will keep only the infection control category. Then you have to proceed with the information. This page, it will open to you. This is almost having like 4 sections, like person affected, information, details of the event, when and where it's happening. Here also you have to select like where it's happening. It's outpatient, inpatient, or in health home care. So after you putting the MR number of the patient, you don't have to do everything manually. There is this search icon after you putting the MRN number, so you can search, and all the information, it will flow from the system directly to the SRS system. Then you will proceed with the mandatory field, as we have almost 11 mandatory field. That one with the start with the greens. So like specific type event. So what's happened to the patients? Like retiring foreign body or an implant going to OR, or then you can specify if it's like injury it's occurred, any involved equipment. Then you have right here in the brief factual description a small story of what's happening. Then if like you have to notify your senior or superior, so you can also put their information. Then it's easy, you find like here to submit and save copy. So quality is everyone responsibilities. So good catch. So what is good catch? Good catch is a program which was found by the patient safety. So it's encourage reporting of near misses and recognizing, appreciate individual and healthcare workers who stop a potential serious adverse event through vigilance and promote intervention, promoting positive patient safety culture. So let's have some example of good catches. So this incident that's happened earlier. This incident was identified through SRS, whereas the resident was taking care of a 35 years old female, gravida 3 para 1 at 40 weeks, admitted to L&D. And the patient was consulted for trial for labor after previous cesarean section. So the patient was seen by obstetric and gynecology resident, and his finding from the physical assessment was tenderness in the previous scar. So this is a good catch. It was notified the superior, then they take the patient for OR for proactive phase to prevent the uterus from rupture. Therefore, the patient was transferred to OR for emergency cesarean section. A letter of appreciation was issued to the for the good catchers and patient safety in identifying, reporting patient safety incidents or preventing a potential harm to the patients. Let's have another example as well. So preventive adverse medication events. This is also from our hospital. This is a real story was happening. So a patient was receiving an ICU by the nursing team and noted to have an ongoing narcotic infusion running through arterial line at a rate exceeding the prescribed dose. Infusion was immediately disconnected due to the ICU nursing team through the assessment and quick action, a potential catastrophic patient outcome that could lead to lose if they are continue receiving from the artery. It could lead to a potential death or losing limb. This is a real good catch. Reporting has also led to initiative led by the anesthesia department in collaboration with logistic department to remove all the three-well stopcock from the arterial transducer with our organization. So from this good catch, we found a problem, so we tried to solve it. So no more 3 stopcock for arterial line. And here, as you see, it was a letter was appreciation letter, and the gift was submitted to the good catcher. Another example, it was preventive misdiagnosis. A 2-day-old neonatal had a spinal ultrasound done on the day of the discharge, which was reported as a normal based. On the report, the neonatal coordinator who was following on discharged patient, outpatient clinic, noticed an abnormality with this baby. Spinal ultrasound report. She was immediately escalated his concern to the physician, and this abnormality was later discovered to be treating spinal cord syndrome. So the baby was referred to pediatric surgery for further investigation and management. So her diligence and quick action have preventing a potential serious adverse outcome to the baby. As well, an appreciation letters was issued to that catcher. Here another video just to have a better idea about the good catch, and it's really very important things that discover could prevent a serious harm to the patients. Let's see it together.
دكتور ممكن بس تعلي الصوت؟
Okay, as we saw here in this scene, it was only the difference, it's the name. So all the vials are the same. So if that patient received that medication, really the patient could be dying. So from very small things, we can find out that something it could prevent a serious harm to the patient and help us to improve it and don't make it happening again, prevent it from happening again while you are reporting to us. So from our database, we can find out these issues. So remember, patient safety is every employee responsibility. No matter of what your job, your position, you are playing an important role in helping providing quality patient care. Thank you. If you have any question, I'm willing to answer. Hello.
في 5 minutes to 10 seconds delay بس نعطيهم فرصة.
ما في مشكلة.
أستاذ ريان.
هلا.
يعطيك العافية، شكرا
الله
لك.
يعافيك.
يبدو ما في أحد عنده أسئلة. دكتور ياسر موجود معنا؟ دكتور ياسر المالك أسيستنت دين.
السلام عليكم.
أهلا
مساكم الله
وسهلا.
بالخير.
حياك الله.
So can everyone hear me? يعني can we make sure that
واضح دكتور.
excellent.
تفضل.
So I know it's been a long day for all our valued interns. I just want to conclude by stating the importance that you know, when you start your internship, you will be each of you working with other healthcare professionals on one of the most important front lines in our healthcare system. And whether you guys know it or not, you by being a healthcare professionals, you have accepted a great and enormous responsibility. So I want all of you guys to be up to the task, comply with all the hospital bylaws and policies, as well as of the internship unit bylaws. I'm sure you've been familiarized with this throughout the day. Most importantly, with regard to patient safety and infection control. I understand Dr. Khalid have spoken to you this morning and have clarified few يعني important concerns from you. لكن إذا عندكم أي سؤال, I'm happy to answer it in the last few minutes. طبعا anytime my email, Ms. Nof and Dr. Khalid will be happy to answer your concerns. I'll give you guys maybe a few minutes, a couple of minutes, I guess. In the meantime, I really would like to thank all the presenters, the great effort and coordination from Ms. Hanan and Ms. Nof. This is an enormous job. I know it's quite difficult to you know, coordinate such a one-day meeting مع الأوضاع الحالية. So thank you all. I guess the interns will be asking through the Q&A, right? Ms. Hanan?
Yes, yes. إلى الآن.
لكن we're sure that they're hearing me. على الأقل, can you guys give me thumbs up or okay if you can hear me, any of the interns? لأنه خاف إنه there is a difference between the audience وال presenters. It shouldn't, right, Hanan?
لا يسمعون.
Okay, cool. Well, I think we could conclude now. Thank you very much, all of you. Have a wonderful afternoon.
شكرا دكتور.